Good afternoon, ladies and gentlemen. It's a pleasure to see so many of you here. Thank you for coming. This is one of the most important moments of the British Pharmacological Society annual meeting, the Gaddum Lecture. And I'm delighted this afternoon to be introducing a fabulous speaker, Valérie Schini-Kerth. Valérie is at Strasbourg University, but according to her biography, I'm just talking to her just now, she's been in most of the finest centres in the world, the Mayo Clinic, Baylor College of Medicine, and in the Johann Wolfgang Goethe University of Frankfurt. And she's a professor of pharmacology in the Faculty of Pharmacy in Strasbourg since 2000. She's going to focus in her lecture this afternoon on endothelial senescence, a novel target to improve cardiovascular health. Valérie, I invite you to give the 2024 Gaddum Lecture. Thank you.
Thank you so much for the kind introduction. First of all, I would like the British Pharmacological Society for giving me this great honor to give the Gaddum International Lecture. Today, what I would like to share with you is the role of endothelial, the potential role of endothelial senescence as a new target in cardiovascular disease. As you can see here, or you have heard this during this meeting several times, that cardiovascular disease remains the leading cause of death worldwide, and this burden of cardiovascular disease is still, it continues to increase. You can see here that from 1990 to 2019, over 30 years, you can see that the number of deaths is on the rise, the prevalence is on the rise, as well as the years lived with disability, such as after stroke, which means we still have to know better what are cardiovascular disease, the underlying mechanism, to propose patients better treatments, better treatment options. When you look, the most important cardiovascular diseases are affecting the circulation of the brain with stroke, the circulation of the heart, the coronary circulation, coronary heart disease, heart failure, but also the circulation of legs with peripheral artery disease. When we look carefully, we can see that normally with increasing age, of course, patients are at increased risk of cardiovascular disease. But in subjects with no all risk factors optimal, no cardiovascular risk, you can see that the disease starts after 75 and then increases slowly. You can also see on this slide that if you have one risk, which factor not optimal, you will increase the risk, which is even further increased with one elevated risk factor. Further elevation is one major risk factor, and here you can see two major risk factors. Which factors are listed here on the right-hand side, and we have identified a high number of risk factors. And again, a major one on the top of the list is suboptimal diet. It has been shown that in the United States, there are about 95% of people have a suboptimal diet. It's followed by tobacco smoking, high blood pressure, high body mass index, physical inactivity, high fasting glucose, and cholesterol. So the number is quite high. Now, what is the underlying mechanism for most of these diseases? It is the development of an atherosclerotic plaque, which can lead to an atherothrombotic event. Actually, the development of those atherosclerosis is actually a very early event. It starts with the appearance of fatty streak, which then will progress. It is an inflammatory disease, and it leads to the accumulation of monocytes and the uptake of lipids, oxidized lipid, forming a lipid core. And then when you have a major plaque, you can have plaque eruption or rupture, which of course will develop instantaneously and thrombus formation. What is of interest to see is that this fatty streak is a very early event. It has actually been observed in children before 10 years of age. So it starts very early on in our aging process. And we can see that at this stage here, at the fatty streak, we can already identify endothelial dysfunction, one of the early events. It is linked to an imbalance between endothelial endosynthase formation and oxidative stress. It leads to activation of monocytes, adhesion, lipid accumulation, and so on. Now, endothelial dysfunction, again, is one of the early events. Now, why are those endothelial cells so important? You can see here they form a monolayer covering all types of blood vessels as well as the heart cavities. And here on the right-hand side, you have a schematic indicating why those endothelial cells have such an important role. They produce potent protective factors, vasoactive factors like nitric oxide produced from enos, relaxing the underlying vascular smooth muscle by the cyclic GMP pathway. A second mechanism is endothelium-dependent hyperpolarization. It starts in endothelial cells with a hyperpolarizing signal which goes via myoendothelial junction to underlying smooth muscle cells to cause relaxation. A third factor is prostacyclin, produced by the arachidonic acid cascade. It's also a vasodilator via the cyclic AMP pathway. And we know that nitric oxide and prostacyclin interact in a synergistic manner to very effectively prevent platelet activation. In the cardiovascular system, in all blood vessels, nitric oxide is one of the major factors. Prostacyclin is a minor one, and endothelium-dependent hyperpolarization is an important mechanism in large coronary arteries, as important as nitric oxide, and also in the coronary microcirculation. When we look more carefully why nitric oxide is so important in the cardiovascular system, it not only is a potent vasodilator, but it helps to keep the arterial wall in the quiescent stage, inhibiting smooth muscle proliferation and the development of fibrosis. It also inhibits major events in the development of an atherosclerotic plaque, mostly by inhibiting NF-kappa B activation. It prevents the expression of chemoattractant molecules like MCP1. It inhibits the expression of adhesion molecules like VCAM1. It prevents oxidation of LDL. And very importantly, it's a potent inhibitor of tissue factor expression, the activator of the coagulation cascade. And NO, as indicated, is a potent inhibitor of platelet adhesion and activation, and also of monocyte activation. Now, how can we assess the health state of our cardiovascular system of endothelial cells? There is a way, which is flow-mediated vasodilatation. We place a cuff on the forearm, which is inflated over your systolic blood pressure, so you stop blood flow, and you measure the diameter of the brachial artery. After 5 minutes, those are the guidelines, you release the cuff, and what you see, you have, of course, a dramatic increase in blood flow starting again, which will induce shear stress on endothelial cells. And endothelial cells have the mechanoreceptors to detect the level of shear stress. And in response of shear stress, endothelial cells will release nitric oxide, causing a dilatation of the blood vessel. And the extent of this vasodilatation is a good indicator of the health status of your endothelial cells. On the right-hand side, you can see that a person with no risk factor, healthy subject, the vasodilatation amounts about 10%. And you can see if a person has 1, 2, 3, 4, 5 risk factors, you can see that the FMD value will decrease very rapidly. You can see here 2 risk factors, you already reduced by more than 50% your FMD value. And again, when you look at the risk factors, it's very easy to have 2 or more risk factors. Now here again, you can see the impact of aging on the vasodilatation induced by the endothelium. Here it's an experiment by Dr. Taddei from Pisa, and they infused acetylcholine, were infused directly in forearm blood flow to look at the vasodilatation. Those are normotensive subjects, and you can see with increasing infusion of acetylcholine, the vasodilatation is increased, the forearm blood flow is increased. Here you have the data from young adults, like less than 30 years of age. You can see that even in the category which are still extremely young, 31 to 45, we had a decreased forearm blood flow in response to acetylcholine. And you can see that the older the person gets, although we still have young here adults, you can see that the decrease is very pronounced. So we have a decrease of the endothelium-dependent vasodilatation, and if we analyze the response of the vascular smooth muscle to sodium nitroprusside, a donor of nitric oxide, you can see that the vasodilatation is almost, except here similar, indicating that it is the endothelium which has a pathological function with aging. Now, when we look more carefully in the coronary circulation, where atherosclerotic plaques very often develop, you can see here in black the most frequent sites of development of atherosclerotic plaques, the frequent sites, and you can see actually that the plaques develop not everywhere. They're developed at very special places. Here the bifurcation, you can see. Each time there is a bifurcation of a large coronary artery, this is an arterial site at risk, which of course we need to understand what's happening here at those bifurcations and how can we protect those areas at risk. When we look here, the development at those arterial sites at risk, here is a schematic showing that we have atherosusceptible sites. They are characterized by premature endothelial cells, and in particular, when you look at here's the heart, here's the aortic arch, here the bifurcation, and in red here I indicated the sites which are characterized by disturbed flow and low levels of shear stress. And when you look on the right-hand side, the aortic arch has been open, and you can see that the inner curvature, you can have a blue stain indicating that we have senescent endothelial cells. However, when you look at the outer curvature, it's a pale blue, or you have almost no senescent endothelial cells. And you can see more easily here in the outer curvature, we have only pale blue on the endothelium, whereas in the inner curvature, cells are highly marked, which indicates that the inner curvature is an arterial site at risk with a development of senescence. Now, the difference is mostly due to the fact, when you look at the aortic arch, that here, of course, we have disturbed flow compared to the outer curvature, where you have more laminar shear, higher levels of shear stress, and the same at the bifurcation. This is a site which is arterioprone, and where you can identify pro-inflammatory and pro-thrombotic responses. Whereas when you look at the thoracic aorta or the ascending aorta here, we have a site with laminar flow causing high shear stress, and shear stress is the most potent activator of endothelial cells, inducing arterioprotective responses, anti-inflammatory, anti-thrombotic responses. And this is mostly subsequent to the increased formation of nitric oxide, and we'll show you that in a few minutes. And here again, the aortic arch with the bifurcations here, and they actually looked at the levels of shear stress in those, of wall shear stress in the aortic arch, and they also looked at the marker, the expression of the adhesion molecule VCAM1 protein in the aortic arch. And you can see that in the inner curvature, where we have seen senescence before, you can see that staining of VCAM1 is extremely high compared to the ascending aorta, where you have high levels of shear stress, almost no VCAM. So big difference. And the same also when you look at the branches here, you have a high level of VCAM expression at the site where we have seen senescence before. Thus, senescence, it's moving. We also looked in the aortic arch here, what's happening for expression, and we can also show that the aortic arch has higher levels of VCAM assessed by Western blot compared to the thoracic aorta, where we have high levels of shear stress. Interestingly, we also see an increased expression of sodium glucose cotransporter 1 and 2 in the aortic arch compared to the thoracic aorta. Of interest here, the animals we study are very young with Stargardt, 12 to 15-week-old. That means even in very young animals, when you look carefully at sites at risk, you can see already activation present at those sites. It means even in adulthood, those sites at risk are not perfect or optimally protected. And you can see here some other models where you can see induction of senescence. Here is a high-fat diet treated mice. It's an LDL receptor knockout mice. It's a model of atherosclerosis. You can see here the aorta, which is open here, the two branches from the aorta. And following 2 weeks of a high-fat diet, you can see some blue appearing in the inner curvature. 6 weeks, you can see clear blue staining, and 12 weeks even further. So you can see Here we have a major site at risk, the inner curvature, exposed to disturbed flow, blood flow, and low levels of shear stress. We also can see in here another model, which is a model of young rats compared to old rats and treated by streptozotocin to induce diabetes. You can see that in the aorta, here you can see that thoracic in the abdominal aorta, you can see more blue stain in the abdominal aorta in the old animal compared to the young. And when you induce diabetes by infusion of streptozotocin, you can see that the blue stain is much higher, indicating that you have a more pronounced senescence. Now, what is senescence? Actually, senescence, we will see that senescence can promote the development of endothelial dysfunction. It is an early event which will lead to endothelial dysfunction. And this senescence is associated with major cardiovascular risk factors. It can be induced by exposing cells to disturbed flow, low levels of shear stress, but major players in cardiovascular disease stimulate the induction of endothelial senescence, like angiotensin II, oxidized LDL, high glucose, and pro-inflammatory cytokines like TNF-alpha and IL-6. You can see here on the right-hand side a culture of endothelial cells. You can see the cells stained in blue. There is increased S-beta-gal activity. They are flattened, and the surface is much larger than the healthy endothelial cells. And you can see that this endothelial cell status is associated with an increased level of oxidative stress in endothelial cells, increased level of senescence associated beta-galactosidase, the gold standard marker, and increased expression of proteins P16, P53, P21, which are inhibitors of the cell cycle. So they will prevent proliferation of senescent endothelial cells. And this leads to a major change in cellular homeostasis. We will see development of pro-atherosclerotic, pro-inflammatory, pro-thrombotic state, and the secretion of a senescence-associated secretory phenotype with release of enzymes, of chemokines, of adhesion molecules. And it will lead to the development of endothelial dysfunction. And what evidence do we have that it leads to the senescence leads to endothelial dysfunction? Here's a very elegant experiment which was done for a group in the USA. So what they did, they transfected a rat aortic segment with an adenovirus for P53. You can see here the brown color of the endothelium. Here you can see beautiful endothelial cells overexpressing P53, and it was compared to the control aorta, which we used the control vector. And you can see overexpression of P53 in the endothelium resulted in very pronounced impairment of endothelium-dependent relaxation to acetylcholine compared to the control. And this was associated with a reduced formation of nitric oxide. That means in overexpression of P53, which is a marker of endothelial senescence, contributing to inhibit cell proliferation, leads to endothelial dysfunction. And thus, endothelial cells, an early event which can lead to endothelial dysfunction, appears as an interesting new target for cardiovascular health. So to study this point, we developed different models of endothelial senescence. Here's our replicative endothelial senescence model. We collected pig hearts from the slaughterhouse, we isolated the coronary arteries, we prepared endothelial cells, and then we studied P0 primary culture, passage 1, passage 2, passage 3, passage 4, and we check how the biological response of endothelial cells is affected. You can see here senescence-associated beta-gal staining with X-gal, and you can see from P1, P2, P3, P4, a very strong increase in the level of senescence. We can also do the same experiments using this time a fluorescent marker of S-beta-gal, and you can see exactly the same with each passage. The number of senescent cells is increasing dramatically. And you can also see here on the top, when you did cell cycle analysis, you can see that the senescent cells, they stay in the G0, G1 phase of the cell cycle they are not able to progress into S and G2M phase. This is classic senescence, and this state is associated with the expression of the senescence marker, P53 here, P21 here, and P16 overexpressed in senescent cells compared to healthy endothelial cells. Now, there is also models where you can activate, induce premature endothelial senescence, and you can see here that enos-derived NO plays actually a very crucial role to prevent the induction of endothelial senescence. Here what we did, we used healthy endothelial cells, P1 passages, low passage, and we exposed them to nitro-L-arginine-methyl ester, which is an inhibitor of NO synthase. And so we block the formation of nitric oxide. And as you can see here, when you inhibit NO formation, you increase the level of S-beta-gal activity. You induce senescence. And what you can see that the treatment blocking NO formation is associated in the healthy endothelial cells with a decrease of the level of expression of enos, and also with a decrease formation of nitric oxide in those endothelial cells. And actually, when you look at the senescent cells, the enos level is low compared to the healthy one, and also the formation of nitric oxide is low. So when you block NO formation, you will promote the development of endothelial senescence. And we look at what are the consequences of this induction of endothelial senescence. Here's a model where we assess the anti-aggregant platelet inhibitory effect of endothelial cells. So we use washed human platelets. They were studied in a platelet aggregometer, and you can see with adding thromboxane analog U46619 caused a very strong platelet aggregation. If before you add the inducer of platelet activation, you add endothelial cells, very low numbers. Healthy, those are P1, healthy endothelial cells, you can completely prevent the development of platelet aggregation to the thromboxane mimetic. If now we add the P3 cells, the same numbers, you can see that they only partially inhibit platelet aggregation. Means that they have a reduced ability to prevent platelet activation. Not only have they a reduced ability to inhibit platelet activation, but also the senescent endothelial cells here at P3 show very high levels of tissue factor and of tissue factor activity, which means that they will promote thrombus formation because they are unhealthy and they have a reduced formation of nitric oxide. We next, I can move forward. Yes, here. We looked what are the underlying mechanisms leading to endothelial senescence. And we confirmed that actually senescent endothelial cells here at P3, they show higher levels of higher formation of reactive oxygen species than the healthy P1 endothelial cells. This was evaluated using the dihydroethylium staining. And you can see when we treat with the antioxidant N-acetylcysteine, apocynin, inhibitor of NADPH oxidase, or indomethacin, inhibitor of COX, you can see that we prevent this high level of ROS formation. And when we look what's happened here at the senescence activity, you can see P3 have higher level. We treat with those antioxidants, you can see that we decrease the level of senescence. And the same can be observed when you look at the senescence marker, P53, P21, P16. The P3 cells, the senescence show high level, and treatment with the antioxidant was very effective in preventing this expression. So induction of senescence is a redox-sensitive event. And we next looked about the underlying mechanism, and we identified that the local angiotensin system is actually a very good driver of the transition from healthy endothelial cells to senescent ones. You can see here when you treat P3 endothelial cells with pyrindoloprilate, this is an ACE, an angiotensin converting enzyme inhibitor, you can see that we decrease the level of S-beta-gal activity. Similar effect were observed when you use the AT1 receptor antagonist losartan. We were able to decrease the level of senescence. And actually what happened is that when we induce senescence here in the P3 cells, we upregulate the expression of angiotensin converting enzyme, and we upregulate quite markedly the expression level of the AT1 receptor indicating that this angiotensin system is highly active and it is a redox-sensitive event. You can see here NAC is fully inhibiting the expression of ACE and the AT1 receptor. We next also looked the consequences when endothelial cells are activated as senescence. Here again, the same data I showed you before, passage 1, 2, 3, 4. There's the S-beta-gal activity. And once cells are activated, they promote shedding of extracellular vesicles or microparticles. And we were able to measure those microparticles using phosphatidylserine prothrombinase activity. And you can see that with increasing levels of senescence, we see increased shedding of those extracellular vesicles or microparticles. And what is interesting here is that when you use microparticles from senescent endothelial cells and you apply them here to healthy endothelial cells, you are promoting the induction of senescence. That means those vesicles released by activated cells will promote the propagation of a senescent message. And you can see when we use the microparticles or extracellular vesicles released by healthy endothelial cells, they do not induce such a stimulator effect. So those microvesicles, the circulating microvilli, will actually propagate the pathological message. And this stimulated us to look what's happening using it in humans, using a translational approach. We have previously shown that in patients, cardiac patients with acute coronary syndrome, we have an increased level of circulating microparticles. And those microparticles we have been collected, we have isolated them, they have been washed, so we have purified those microparticles, and we applied them to endothelial cells to see the consequence. Endothelial cells in a healthy state, passage 1. And you can see here are the microparticles, which circulating microparticles from 6 acute coronary syndrome patients. They were applied to a passage 1 endothelial cell, healthy endothelial cells, when you can see that each of those 6 patients, the microparticles stimulated the induction of senescence. When we do the same thing and use microparticles from healthy volunteer, we absolutely do not see anything. That means those microparticles circulating from the blood circulation of those patients, they will propagate the message of senescence to healthy endothelial cells. And we looked even further this mechanism because we know that endothelial cells exposed to low shear, disturbed flow, or to high shear are completely different endothelial cells. So what we did, we exposed the endothelial cells exposed to low levels of shear stress. We used a cone plate viscosimeter, and you can see when you add microparticles from those patients to those cells exposed to low shear stress, we see an upregulation of P53 and of P16, indicating that we are inducing senescence. However, if we apply the same number of microparticles to endothelial cells exposed to high levels of shear stress, you can see not much is happening for the level of P53, but also at the level of P16, which means that the microvesicles, the circulating ones, they will target endothelial cells at areas at risk, bifurcation, curvature. And based on that, we were able to propose the following schematic, is that in endothelial cells exposed to high level of shear stress laminar flow, they are healthy, they produce quite a certain amount of nitric oxide, and when we add those microvesicles from acute coronary syndrome patients, the endothelial cell is protected due to the increased formation of nitric oxide. However, if we do the same experiments in endothelial cells exposed to low levels of shear stress, such as bifurcation and curvature, then those microvesicles, the same microvesicle, will now induce premature senescence, cause NENOS, NO-ROS imbalance, or cause induction of senescence, activation of the local angiotensin system, and expression of tissue factor. This, of course, will promote endothelial dysfunction, in particular at sites at risk. So protecting the endothelial cells from the induction of endothelial senescence appears as an interesting challenge. And you can see here, it's not only microparticles from patients which promote the induction of endothelial senescence. There are a lot of different other conditions. And here we tested anthracycline is a treatment which is used to treat solid tumors. And you can see when we exposed healthy coronary artery segments to doxorubicin for 24 hours, and we do X-gal staining, you can see the blue staining is where predominantly the endothelium. That means endothelial cells are highly sensitive to the induction of senescence, much before the induction of the changes in the arterial wall. And you can see also appearance of P53 in those segments. The same is observed also when we treat endothelial cells. Here with epirubicin, we can see very strong induction of beta-gal staining and upregulation of P16, P21, and P53. Thus, endothelial senescence could also maybe contribute to the development of the cardiotoxicity, which is associated with those with anthracycline treatment. Now, of course, one of the challenges we have is we do not know nowadays how to evaluate the impact of endothelial senescence in a whole body. We don't have a technique. So I think it's going to be very important to get new technologies, not only to detect, but also to evaluate the severity of endothelial senescence at the arterial sites at risk, and maybe also to follow that the treatment is effective and decreasing the burden of endothelial senescence. And for this, we developed a new approach with our colleague from the Faculty of Pharmacy, Dr. Andrei Klimchenko. He's a chemist, and he's a really top-level chemist doing nanoformulation and targeted nanoformulation. And we use this approach. What we want to do is when we have sites at risk, where we have premature senescence, what's happening here it is increased, where with the violet part, we have senescence being developed. And when senescence develops, you have new proteins appearing at the endothelial cell surface. And what we want to do is we develop nanocarriers. We load it with a fluorescent dye or fluorinated dye for in vivo MRI. And those nanocarriers will be or are decorated with antibodies to recognize the new surface protein of senescent endothelial cells. And I'll show you some of the data we published not too long ago. And you can see here we looked at the staining of our endothelial cells. Here we have senescent endothelial cells. They were exposed to nanocarriers decorated with VCAM1 antibodies, and you can see the senescent endothelial cells, we have a strong signal compared to what we see in the healthy endothelial cells under basal conditions. A similar signal was also detected in the model of replicative senescence. And why do we know that this signal we detect is targeting VCAM? We did the control experiments where we exposed those activated senescent endothelial cells to the VCAM1 antibody first to cover the phenotype, to mask the phenotype, and then we added the nanocarrier VCAM, and you can see that the signal is no longer observed, both in the angiotensin II premature senescence model and in the replicative model. So the system is working. We are now scaling up, and our goal is to look in vivo where the areas affected by premature senescence are, and maybe developed a theranostic approach to treat particularly those senescent endothelial cells. So now, of course, one of the goals is how can we prevent or reverse endothelial senescence once we detect it? And we know that in the literature, senescence is associated with enos downregulation and with reduced formation of nitric oxide, which of course will decrease the protective effect endothelial cells have on the arterial wall. And we know that, we know since quite a long time that we have a high number of physiological activators. They are some of them are listed here. In particular, shear stress is the most important one. They trigger endothelial cell activation to produce nitric oxide and to protect. Again, most of those activators, they have a bolus of NO over 30 minutes and then it's gone, except shear stress, upregulates eNOS and causes a sustained formation of nitric oxide. And we know since the last 15, 20 years that also nutrition is providing mediators, compounds, which are able to activate endothelial cells to produce nitric oxide and which, of course, could contribute to protect the cardiovascular system. And we studied quite several compounds from nature. And here, for example, we have polyphenols from the aronia berry. And just to show you, on an isolated blood vessel, we can have full relaxation in arterial wings with endothelium, whereas when you get rid of the without endothelium, you have very little effect. So they have strict endothelium-dependent relaxation. And what was interesting is when we looked at the kinetic of NO formation. Here on the right-hand side, cells, those are cultured endothelial cells, stimulated with bradykinin. Here we looked at phosphorylation of eNOS at 1177, the activator site of eNOS. This gives you an indication how long NO is being produced. And here you can see in the statistic that actually we have a very fast, after 2 minutes, you see a high level of NO formation, and this effect is over after 30 minutes. The receptor is desensitized, most likely. Now, what's happening when you look at polyphenols from the aronia berry? You can see here that the eNOS is also phosphorylated. It's quite fast, 2 minutes. And what we see is that the phosphorylation of eNOS remains up to 24 hours. And what was even more interesting for us is to see that when we expose those endothelial cells, the total eNOS here, we see that actually the level is increasing. You can see here. That means not only do we have a sustained activation of eNOS, but also an increased expression level of total eNOS. And a long-term increased formation of nitric oxide, about twofold like we see here, is what we see with shear stress. It could be a very interesting approach to protect the endothelium. We can also see here, this one are polyphenols from purple grapes, and you can see the qPCR data show that we have an increased expression of eNOS at the mRNA level, an increased expression level of the protein associated with an increased formation of nitric oxide observed 24 hours after the treatment. So it is indeed a sustained effect. Now, when we characterize the pathway by how those polyphenols activate endothelial cells, it was very surprising because those anthocyanins, which give the color to the different berries, they cause a redox-sensitive activation of the SARC perfect kinase AKT, which phosphorylates eNOS to produce NO. The same pathway as the pathway activated by shear stress. In addition, we also induce via MAP kinases and PF3 kinase an increased expression of eNOS, higher levels of the protein, which will help to sustain NO formation. So they have an incredible positive profile to protect the cardiovascular system. And that's why we want we characterize further how these anthocyanins are working, are activating endothelial cells to stimulate NO formation. We shift a little bit gears. We tested the blackcurrant berries. This was an interesting product. You can see here some photos of the berries. Why did we study them? It's easy to understand. You will understand very easily. When we analyzed, we prepared an extract, and we analyzed the composition of the extract with Joël Pasmade from Belgium. And you can see that actually 80% of the anthocyanins are conjugates of delphinidine and cyanidine. They are either conjugated to a glucoside, a sugar, or to rutinoside. The same for sending glucoside and rutinoside. And those they are commercially available, we were able to test, and just to show you that this extract with endothelium causes very pronounced relaxation. You get rid of the endothelium, almost no effect. So again, strict endothelium-dependent relaxation. Now, what is the effect of this extract on senescence? We use 2 moles of senescence. Here you have the replicative senescence model, P3 endothelial cells. When you treat with the blackcurrant extract, 1 to 3 microgram per ml, low concentration, we see a decrease in extrahepatic activity. We can also test the angiotensin II induced premature senescence in P1 endothelial cells, and you can see also that increasing the concentration of blackcurrant extract from 1 to 10 was able to significantly decrease the induction of senescence. The sign you can observe when you look at the senescence marker, P53 increased here, the angiotensin II induced premature senescence, like P21 and P16. You pre-treat with the blood count extract, you are able to prevent the induction of the senescence markers. Not only do you prevent the expression of the senescence marker, you have also beneficial effect on NO formation. Here on the T cells at P1, the healthy ones, when you stimulate them with bradykinin, you have an increased formation of nitric oxide, which was assessed by the NO probe DAF-FM. And when you treat with the cells with angiotensin II for 24 hours to induce senescence, and at the end, after that, you apply bradykinin for 50 minutes, you can see that the stimulatory effect of NO formation is very small compared to the healthy on the T cells. However, if you pre-treat on the T cells with the blood current extract before application of angiotensin II for 24 hours and bradykinin at the end to stimulate NO formation, you can see you still are able to see NO formation. That means you are able to prevent not only the induction of senescence, but those cells are still capable of producing and stimulating NO formation, which of course is very important. And we wanted to understand how do those anthocyanins interact with endothelial cells. And again, it was not so easy. The data published are very few data. We know very little how anthocyanins interact with cells. And you can see here we were very lucky using confocal microscopy and this reagent, which reacts with anthocyanin. We were able to see that actually anthocyanins can be taken up by endothelial cells. And what was interesting to see is actually the glucose, the conjugated cyanidin and delphinidin are taken up, whereas the rutinoside, cyanidin and delphinidin, have almost no uptake. So the sugar is very important for the uptake. And since sugar is very important, we were able to see whether or not there is a sugar transporter which is involved. And indeed, when we use sotagliflozin or LX4211, this is a dual inhibitor of SGLT1 and 2, we were able to decrease the uptake of cyanidin threoglucoside and delphinidin threoglucoside, indicating that the sugar conjugate of anthocyanins is important to help those anthocyanins to enter into endothelial cells. And we were even able to see that the senescent cells have a higher uptake of the blood count anthocyanins compared to the healthy P1 cells. And you can see it when you have a higher uptake. Now you can see that sotagliflozin, this dual SGLT1 and 2 inhibitor, has a very strong inhibitor, much more than at cells studied at P1. We looked also at the role of SGLT2 using empagliflozin, highly selective SGLT2 inhibitor. You can see that the increased uptake in P3 compared to the P1 is slightly but insignificantly inhibited, indicating that SGLT2 is also involved, but the major co-transporter is SGLT1. And actually, when we look at SGLT1 and 2 expression, we're able to see that the senescent endothelial cells have much higher expression level of SGLT1 and SGLT2, which help them to enter into endothelial cells and have this nice beneficial effect. So in conclusion from this part, just to show you that senescent endothelial cells, they actually express the sodium-glucose co-transporter, in particular SGLT1, which is helping the conjugated anthocyanin, particularly the glucoside conjugated anthocyanins, to enter and to cause activation of the pathway and increase, of course, have a protective effect. Now to the last part I would like to share with you is, of course, doing work with cells and isolated blood vessels. You always have to be careful because metabolism is very important. Those berries, they are taken orally. And so we did a study. We looked whether or not blood current anthocyanins taken orally are able to improve vascular health in old rats. So we compared young rats to 3 groups of old rats, an old control, an old rat with a low dose of blood count anthocyanins and a higher dose for 2 weeks, all intake, and thereafter we did several studies. Here you can see interesting data. The old rats had higher levels of systolic blood pressure, significant higher levels, and intake of the anthocyanins was actually significantly decreased the increased level of systolic blood pressure. It was highly significant. You can see minus 7.6 millimeters of mercury, and the increase was 9.4 millimeters of mercury. We also looked at the vascular reactivity. We were able to see that in the young rats, you have here the black curve. The old rats had a much higher contractile response to phenylephrine, and treatment of the old animals with the 2 doses of anthocyanins was able to decrease the reactivity. Also, the old animals in the arterial wall, here it's the thoracic artery, had higher levels of ROS formation, which was inhibited by NAC. And you can see the treatment, in vivo treatment with blackcurrant, was able to decrease the level of oxidative stress in this old arterial wall. We also looked at different markers. We were able to see that in the endothelium of the old animal, there was a high overexpression of enos, most likely as a compensatory mechanism. We see an increased level of p53, you can see mostly in the endothelium here, easy to see, and an increased level of monocyte chemoattractant protein 1, and treatment intake of blackcurrant extract was able to improve all the parameters. We also looked at the local angiotensin system because it is important. It is always associated also in human tissues. We looked very carefully, and you can see that in the old animal we have an increased expression of the converting enzyme, here the endothelial signal, and also an increased expression of the AT1 receptor, mostly the vascular smooth muscle, and again the blackcurrant intake was able to improve both markers. And here, just a schematic to summarize, also with our human data, which I did not share with you because those are different pathologies. What we observed is actually in the pathological endothelial cells, what we see, we have an increased level of ROS. This involves NADPH oxidase and this local angiotensin system, where we see overexpression of the converting enzyme of angiotensin 2 and the NADPH oxidase subunit. This will, of course, fuel formation of ROS in a long-term way. And we see an amplifying loop, which is amplifying loop is linked to the overexpression of SGLT1 and SGLT2. In healthy cells, it's a very low expression, but if you have oxidative stress, you will upregulate SGLT1 and 2. This will lead to glucose entry, and this again will fuel to maintain high levels of oxidative stress in aging. And this, of course, if you have high levels of oxidative stress, the NO formation will decrease, enos expression will decrease, you will induce senescence, and you will have different markers which, of course, will promote pathological conditions. And thus, we detect senescence and dysfunction, and of course, promote cardiovascular disease. And we see that anthocyanins, for example, are inhibitors of the induction of senescence. And those agents, in particular glucoside conjugated anthocyanins, are extremely interesting because they are able to decrease this level of ROS in a long-term manner. And this, of course, will reduce this excessive activation of the local angiotensin system, the expression of SGLT1 and 2, and this will lead to to keep your NO formation at a high level, which will protect the endothelial cells and, of course, cardiovascular health. And with this, I would like to terminate and just to indicate that here are actually the active members of our team who did most of the experiments. Here are our senior scientists, cardiologists, cardiac surgeon, vascular surgeon, with whom we have a great pleasure to work together, our international colleagues, and here is our new research center we integrated a year ago, which is exactly perfect for us. It's next to the hospital, so 2 minutes away for collecting samples, perfect. And here is our inside of our new research center and our team, a very international team, and it's a wonderful pleasure to work with all those young scientists. Thank you very much for your attention.
Well, Valérie, you amply demonstrated why we're giving you this award. That was a tour de force. Are there any questions for Valérie? I've got one, Valérie. You referred to the plant extract in blackcurrant and others to contain anthocyanins. So do you isolate the anthocyanin and then administer it? Is that how you do it?
Yes, we have the extract, the romaine, the sugar, and so on.
The reason I ask is that some plants are nitrogen fixing, so although it would require some degree of cycling, another mechanism could be replacing that. But it's a fascinating set of experiments, and we should probably all be taking them, is the bottom line. So I don't see any questions, so I'm going to move, if I may, to present you with your medal and a certificate.
There was actually a question over there.
Oh, was there? Sorry.
Yes.
Oh, please, okay. It's quite hard to see up here, so I apologize if I missed you.
Hello. Thank you, Professor, this excellent presentation. I wanted to ask a question. You work with extracts with rich anthocyanin compounds, right?
An extract with?
You worked with the anthocyanin-rich extracts, right?
That's true. Correct.
But as we know, anthocyanins are they have extremely low stability. How did you solve this challenge?
Yes, this is an important question. Again, when we start to work on different foods, colored foods, one of the first study we did was working on a grape preparation. And again, our colleagues always said the anthocyanins are extremely unstable.
Yeah.
So what we did, we used our juice, we put it on the shelf, on the bench, and we kept it there for 1 month. And we checked the activity before and after. And there was absolutely no decrease in biological activity. Which means once the anthocyanins are in a food matrix, they are extremely stable. But once you isolate them, you have to be careful. You need a pH, a slightly acidic pH to keep them the structure intact, yes.
Thank you, Professor.
Microphone 4.
Probably a slightly silly question, but one I think allowed one at the end of a conference. I also noticed on one of the slides you had cocoa and red wine up. So
yes.
We can all keep drinking red wine and we can keep eating chocolate. So the daft question is, do we need to drink blackcurrant juice on top of that? Or is it an additive phenomenon? Or do you think it's one at a time will do?
Again, it's true, we started our investigation on nut products with a red wine extract, which was provided by the French Ministry of Agriculture. It was standardized, and a lot of different labs were investigating. And we tried to isolate the compounds, and I can tell you red wine is an extremely complicated mixture. It's impossible to isolate. You have polymers, and it changes with time, and so on. So this was definitely not the way to go if you want to get pharmacological evidence how those products are working. But again, a red wine with a high level of polyphenols, which means 3 to 4 grams per liter, is active. Of course, as a pharmacologist, I never recommend people to drink red wine because we have the other part of the wine, of course, the ethanol. So I think, and that's why we moved into other products, and there are quite a lot of fruits, very interesting one, in particular the blackberry. The aronia berry is a berry which has over even 7-8 grams per liter of polyphenols, extremely high. Of course, on your tongue, it's highly astringent, which makes it not so easy to take, but blackcurrant is a very interesting alternative. Yeah. I think it's important to have a healthy diet, and there are now a lot of data indicating that healthy diet provides really a big value for cardiovascular health. Yeah.
So, Valérie, it's my duty now to present you with the Gaddum International Lecture medal and certificate for an outstanding lecture, and I'll ask the audience to thank you once again. Come to the final phase of our wonderful P24. I'm biased, of course. But I'd like to invite Professor Mark Evans, our meetings chair, and thank him, perhaps as he comes up, for the incredible work he and his meetings committee have done for this program. And Mark will read out the prizes that we haven't given out. We like prizes here, so we're giving out some more. So thank you, Mark, for all you've done for us.
Thank you very much. I'd like to thank the meetings team personally. They've been fantastic, and if you think I've done work, you ought to see what they've actually dealt with to get us here today. Now, we've got some prizes here. There's quite a few. We decided that we're one big family this year, and there's lots of young scientists out there that are not necessarily represented at all times. And I think it is important whether we are in education, clinical, or fundamental pharmacology, we recognize everything. And we recognize that we all learn from each other. So we've given out prizes for posters by theme today, and then we've got an overall prize winner. There is some jeopardy to this for me because, of course, people had travel arrangements ahead of time, and a number of people may not be here to receive their prize. Now, this doesn't mean it's not important to them, and I found that out this morning when Isabel came and grabbed me to go to a particular poster on time because the candidate had a train and then a plane to catch and was desperate to have their poster assessed before they left. So we kick off with the Cancer Prize. And I apologize if I get any of these surnames wrong. I have no phonetic guide, and I failed first time of asking O-level English and French. Now that could give me an advantage, I don't know, we'll find out. So for cancer, we have Linda Wanika. For cardiovascular, we have Joshua Dingham. For clinical pharmacology, we have Kathleen Scullion. For drug discovery, sponsored by RSC, we have Mark Suave. For education, we have Jemima Weir. For GPCRs, we have Kylie Hornaday. For inflammation, immunology, and infection, we have Varuna Jayasinghe. Molecular and cellular pharmacology, Charles Lay. Neuropharmacology, Rishi Pat. Pharmacogenetics, Maya Magese. For safety pharmacology, we have, this is a difficult one, Luke Ocker-Husen. The other category that didn't fit into any category that we could think of at the time, Joanna Binns. And then we come to the overall poster prize winner, which was selected from all of these candidates. The top of the tree for this meeting, Kathleen Scullion. And this was for her poster on novel point-of-care assay for drug-induced liver injury. Then we have our best undergraduate poster. This goes to Ralph Greenwood for his study on augmented bladder contractions in a mouse model of Alzheimer's disease. Another prize here, the Dom Spina Prize for experimental design and analysis. And this goes to Fatimo Ojuade. And this was for a study on metabolic and calcium modulatory effects of ethanol fraction of Pacetina nigrescens in pancreatic beta cells. The subsequent, yes? No. This man is about to present another prize.
Yes, okay. Thank you for the applause, though. So I have come from the National Centre for the 3 Rs, which is the replacement, refinement, and reduction of animals in research. And this year we set up our inaugural Arrive poster prize at BPS, which we're very thankful for BPS and Pharmacology 24 to help support. This award goes to the poster that best exemplifies transparent reporting of animal research as set out by the Arrive guidelines. And our judges, which included myself and my colleague Elliot, were particularly impressed by the transparent reporting that we saw across the board. But the prize this year goes to Sofia Fontana-Giusti for her work on the protective mechanisms of TAT-Beclin-1 during chemotherapy-induced neuropathic pain. Unfortunately, she is ill, but her professor, Gary Stevens, is here to accept that prize on her behalf.
Now, finally, we come to the best oral communications. Each session, we selected one to give a bit of jeopardy here. So I'll read out the prizes per session. Louise Rabbit. Chang Liu. Aya Ali. Rachel Cameron, Ryan Duffy, Gael Meheb, Beth Strellis, Nicola Rudy, and then we come to the best overall oral communication. And this is Gaela Meheb for her study on the effects of omega-3 on human coronary vascular tone induced by neurotransmitters. And that concludes our prizes for this year, Mark.
So, ladies and gentlemen, all good things must come to an end. So I'd like to thank each and every one of you for spending the time here over the past 3 days and making this gathering of 771 pharmacologists or people involved in therapeutic innovation from 51 countries here in Harrogate such a giant success. I'd also like to take this opportunity to again thank the BPS events team led by Isabel with Becky, Bonnie, Mariam and Nicola, who worked tirelessly on this for many months, and for the entire BPS staff team who've been here in force to try and make this an enjoyable experience for all of you, including a wonderful gala dinner last night. I'd like to thank our sponsors for this meeting who've made it possible, especially our gold sponsor, Elsevier, who we hope to collaborate with again. Member involvement in this society continues to be our highest priority. Please share your ideas, engage with the staff, the committees and other members, and submit your work to our groundbreaking journals. And I'd like to take this opportunity to thank the journal editors for the British Journal of Pharmacology, Peter Ferdinandi, British Journal of Clinical Pharmacology, Serge Kramers, and Pharmacology Research and Perspectives, thanks to Jennifer Martin. An additional thanks to all the editors, and if you'd like to be an editor, please just apply to join one of our editorial boards. So, to all of you at the British Pharmacological Society 2024, I invite us to gather again for Pharmacology 2025 between the 16th and 18th of December 2025 in Belfast, Northern Ireland. I look forward to seeing you all there. Please have a safe journey home, and thank you so much for making this such a success. Thank you.